All right, neonatal sepsis. So this is obviously a common thing that we see. It's one of the probably more familiar things y'all are, I would guess, in pediatrics. If you're going to be familiar with anything, neonatal sepsis is one of those things. So specifically, this is for children less than 30 days of age, which is what a neonate is, all right? So we're not talking about older kids that are 9 months or 2 years or 4 months or whatever. This is purely neonatal sepsis and what we're dealing with. So childhood mortality, this is one of the largest that you can see. 5.9 million children died under 5 in 2015, about 16,000 children every single day. 75% of those die under 1 year of age, and 45% of those die under 1 month of age. So neonatal sepsis is a huge global burden kind of throughout the world. So as you can see here, most common deaths among children under 5 years of age, these statistics from the 2015 timeframe. There on the right, neonatal 0 to 27 days, you can see 3% of those are pneumonia. Then you have these intrapartum complications at 11%. Prematurity is usually the most highest, and then you have neonatal sepsis specifically at 7%. Cause of neonatal death. So really a big burden. The different causes of neonatal sepsis, infections being 25% of the causes of neonatal death worldwide. So it's a pretty big problem that doesn't include tetanus, which we don't really see a lot around here, honestly. So, which is a good thing. Tetanus is pretty scary. So. Neonatal mortality every year, nearly 40% of all under 5 deaths are in the infantile neonate period. 3/4 of all newborn deaths occur in the first week of life. So in developing countries, nearly half of all mothers and newborns, they don't receive skilled care. So that's why we really hit home a lot with neonatal resuscitative care with you guys, going to a lot of deliveries when you're on your nursery rotation, as well as when you float back into call. Because if you can take care of these babies right at birth, then you really can prevent a lot of deaths, okay? So Bob tomorrow hopefully will give you the neonatal resuscitation lecture tomorrow, and then do some practicing. And then certainly as you rotate through nursery, then we want you to get plenty of practice to go into deliveries, resuscitating babies, bagging, all those kind of things. So, But up to 2/3 of newborn deaths can be prevented if you have good, effective resuscitation, good, effective knowledge about how to treat newborns and what's appropriate. So oftentimes we get neonates referred in here that are 7 days of life, showed up with a fever to an outside facility. They put them on amoxicillin, send them home, and then they come here because they're not better, right? Because that's not an appropriate way to treat a 7-day-old. So we really want to emphasize exactly what you should do with infections in neonates. And that, once again, we're talking about up to about 4 weeks of life, okay? So when you classify neonatal sepsis, early onset, days 1 through 3 of life, acquired usually from mom, 85% within the first 24 hours of life, and then 15% on up into 3 days of life. And then later onset neonatal sepsis is after day of life 4, and it's usually acquired from other sets of environment. So one of the common questions I get asked in nursery is, why do we only do blood cultures on newborns? So if you rotated through nursery, you know within that first 24 hours of life, typically if we're just doing a rule out sepsis or if we're typically just doing a risk of sepsis, then we only draw blood culture. We don't do like CSF and urine and those things, right? That's because with early onset neonatal sepsis, it's pretty rare to have other causes of problems besides blood, okay? Now, I will say that we accidentally have found some early onset UTIs here because interns were drawing urines in the first 24 hours of life, not really knowing they weren't supposed to, and lo and behold, we cultured positive urines on really sick babies. And so we here, and you, when you go out to work, do tend to probably think about urine maybe a little bit earlier in life, but you're not going to really see that in literature, because in the first 3 days of life, honestly, out there in literature, it shouldn't be anything but blood. You shouldn't really have signs of meningitis or UTIs or other things. It's just we do that different here, okay? So you should just know that kind of. Pathogens that we see in neonatal sepsis, so early onset, E. coli has now become the most common pathogen that we see. All right, used to be group B streptococcus. We don't screen GBS here. It is the second most common as neonatal sepsis worldwide, okay? So if you're talking about first world countries, developed countries, those kind of things, if you ever go practice there, then GBS is going to be a big part of what you do, including GBS prophylaxis, all right? So we test mom around 37 weeks with the vaginal swab. If she's positive or she's had a history of other births having positive GBS status, then we give penicillin during delivery, right? And so GBS prophylaxis. E. coli coag-negative staph is something that we see, but oftentimes here we consider that more of a contaminant. Haemophilus influenza, listeria, all those kind of things. And then late onset, so after 3 days of life, then you're talking about Staph aureus, your gram-negatives really enter into there, yeast and some of those kind of things, okay? Risk factors for early onset neonatal sepsis: maternal chorio, preterm delivery, rupture of membranes over 18 hours. Those are the most common types. And then you have some of these other things that kind of factor in there. That's really a part of our everyday life. So it's a little bit hard to differentiate those. So chorioamnionitis, y'all deal a lot more than I do with this from a maternal standpoint, so you kind of know what you're doing from that standpoint, which gives you a good broad picture of what's going on, right? So infection of the amniotic fluid, the membranes, placenta, deciduous. So basically everything that's surrounding the baby is infected and a problem, and it's causing a problem with mom. And so the chances are the baby's going to have some degree of complications from that. So maternal fever, so over 38 plus at least two of the following. So maternal tachy, leukocytosis, fetal tachy, any uterine or fundal tenderness, and any foul-smelling amniotic fluid. I will say that the last one is something we say a lot, and it's not very sensitive truly to infections, honestly. But chorioamnionitis risk factors, so low parity is spontaneous labor, prolonged rupture of membranes, multiple exams. So if they're requiring multiple exams to see where they're at and some of those things, you have the risk of introducing infection. Meconium involvement, and then internal monitoring, which we have to sometimes do, right? Do y'all still do fetal scalp monitoring? You haven't done that yet that you know of? Okay. So chorioamnionitis, the incidence, so 14 to 28% of women delivering less than or equal to 28 weeks. Incidence inversely related to the gestational age. So if their incidence is higher, with the more premature they are. Does that make sense? Positive amniotic fluid cultures, less than 1% at term with intact membrane, 32% preterm with intact membrane, and as high as 75% with PPROM. So positive cultures may not always correlate with the clinical signs of chorio. Not all culture bacteria are pathogenic to neonates, but when you recover a pathogen, then it's usually pretty significant with the neonate as well, all right? Preterm birth, low birth weight. Prematurity in itself is a risk factor for sepsis in the neonate, especially early onset. Once again, that's inversely related due to complications of labor and delivery to the immune system immunity. So, caveat. The asymptomatic preterm infant delivered solely for maternal reasons without prolonged rupture of membranes, they may not require sepsis evaluation. I will say, though, we typically, that says 35 weeks there. I would say we're probably getting down to more like the 32-week mark. If they're below 32 weeks, we're probably going to do a blood culture or something anyway, plus or minus Amgen. Certainly, if they're really preterm, less than 30 weeks or something, we'll probably almost always put them on Amgen. But if you got a 32-week prem that just came out because mom was having preeclampsia, maybe went into early labor, and the baby otherwise just came out and did fine, we may not necessarily do a blood culture. We may not necessarily do a septic workup. We may just kind of watch them and see what's going on, okay? Rule still applies, though. If you're ever going to start antibiotics, you probably should think about doing some cultures first, okay? Rupture of membranes over 18 hours is the mark. It's generally accepted as the prolonged factor. If they're over 24 hours, if no other risk factors, then it increases the risk of sepsis at least 1%. So if you have chorio associated with that, then really the risk factor for that neonate goes up at that point. So this was a study back down in 2014. It's a single study that had premature rupture of membranes, and 4% remaining had culture-proven neonatal sepsis. The risk factors in this study, neonatal sepsis in the setting of prom, so if they're less than 34 weeks, if they're small, if mom had fever or choreo, if the rupture of membranes over 48 hours, if neonates have thrombocytopenia, which is just a general factor. If a neonate has thrombocytopenia, sepsis should be really high on your list at that point. And then certainly elevated CRP as well. Take-home message from that study, each risk factor is important, but when an infant is a combination of more than one risk factors, we really should start thinking about covering for sepsis no matter what, especially if they're premature. So evaluation for early onset neonatal sepsis, blood culture is the key to that one, all right, CBC. So CBC, you're probably going to find a difference. Who was it? Joy, that I was talking to you in the nursery the other day about this. So CBC is going to be controversial based upon your consultant that you're dealing with, okay, and possibly pediatric COs. So some of us really like them, some of them don't see any use to them. I will say that when we can get a band count from our percentages, you know, differentials, your neutrophil percent, your lymphocyte percent, premature or immature neutrophil count or band count, we can't do here. If you find yourself in another place that can do it, then an immature to mature ratio of 2 is really, really important. And so a band count, an I/T ratio of less than 2 is really significant for not having as much sepsis. If it's over 2, then you have an increased risk of sepsis, okay? So if you have more immature neutrophils, your risk of sepsis goes up drastically, okay? So that is the primary reason, along with obviously white cell count, but how many neonates have you seen come out on day 1 that has a white cell count of 28 and the second day it's down to 14, right? So there's an inflammatory response that really happens. Same thing with CRP. If you check a CRP less than 12 hours of life, then it's going to have a lot of inflammatory response and maternal factors involved with that. And so you want to wait till after 12 hours of life to get that to really start reflecting more of the neonate than what the neonate just journeyed through. Does that make sense? All right. And so same thing would be true with the CBC. Platelet count, any signs of thrombocytopenia, once again, should increase your risk of sepsis. So I'm probably not going to fault you for not doing a CBC on your initial septic workup, but I would fault you if you don't have a blood culture done, right? Okay, so blood culture is the key. And then, like I talked about, for early onset sepsis, in certain situations, we'll want you to go ahead and do a urine or CSF. CRP can give us a little bit more information. I tend to like CRP, I think, more than any of the other consultants do here. And so it just really kind of depends on what you think. I can send you, I just actually read an article about CRP and ferritin levels in Pediatric Review in the United States yesterday, and it gave us really specific information of when the CRP is really useful in certain scenarios, and I can forward that on to you guys after this. Procalcitonin is Bob likes procalcitonin. We can't do that here. He would lobby to get that here if we could. Obviously, if they're having any type of respiratory symptoms, chest x-rays, something to think about too, okay? Blood cultures, so peripheral blood cultures are much more superior to, like, if we have a UVC in or if you have some PICC line or something like that in. Obviously, if you have a central line in with the new fever, you should always do 2 cultures, one peripherally, one off the central line. Sometimes in the really young neonates, we'll only do a culture off the line, but you should always get a culture off the line. Does that make sense? So if the line culture is positive, sometimes we'll add an additional peripheral culture to see if it's actual bacteremia or if it's a line infection. But you should always have a culture of your line if you have it. But when you're doing your initial workup, you always want to do a peripheral sample, at least 1 ml. Our bottles say 1 to 3 mLs. I will tell you that the more blood you put into a blood culture bottle, the more sensitive that culture is going to be and the less chance that you're going to have a contaminant, okay? So contamination risk of blood cultures go up highly with less blood volume, and obviously not cleaning good enough and some of those kind of things too, okay? So if it's a 26-week, 700 gram, I don't want you to pull 3 mLs off of them. If it's a 15-day term healthy baby, I want you to pull 3 mLs off of them. Does that make sense? All right. And then the other factor is, well, skin should be prepped, that's there. But the other factor is that we have to start doing here is you have to get that blood culture before your antibiotics are given, okay? You order stat antibiotics, your nurses are going to give stat antibiotics. They're not going to check with you or lab to see if the blood culture and all the cultures are done. So we want to get those stat antibiotics in there. That means not only should you be doing your CSF and your urine, but you should also do your blood cultures in your labs too, okay? All right. So that's also going to kind of help prepare you guys for the future and being able to do venipunctures and line draws and those kind of things as well. So we kind of already talked about this. White blood cell counts, not very helpful. Neutrophilia or neutropenia may be helpful. Thrombocytopenia certainly can be helpful. And then an immature to mature band count can be the most helpful thing. CSF analysis, if the sample is not processed within 2 hours, CSF white blood cell counts and glucose concentrations decrease significantly. So how many cultures do you see setting up there waiting for us to get the patient inpatient so we can charge those labs to the inpatient versus ER file or something, right? So it does affect your blood sample. So it's one of those things that we need to kind of get those processed soon enough. Mean CSF white blood cell count in an unaffected infant less than 10 plus or minus 2 standard deviations. So I will tell you that in babies, especially less than 7 days, having some white blood cells in your CSF is a normal thing, okay? It doesn't have to mean infection. Now, there's some variation of, once again, consultants in what we allow and alleviate and not. Our protocol book says over 5 white blood cell count in CSF, we treat for meningitis. I think you probably have to look at your clinical scenario, right? If you got a baby that has 1 fever, 38 rectally, never has a fever again, always acts normal, and you have 6 white blood cells in the CSF, I personally am probably not going to treat that, okay, for a full 14 days if your culture is negative. But if you got a kid that's in DIC, sick as snot, and then has white blood cell counts of 10 in the CSF, we may treat that, right? So it just really depends on what you find. I will tell you that our cultures of our CSF are horrible here for whatever reason. I don't know why. But we've only, I actually did some data that I can show you guys, and we catch very, very few culture positive CSFs here. And so it's a perfect example in nursery right now, right? Liam. So Liam had, what did we end up with? 260 white cells with chlebacteremia, and we didn't grow anything in the CSF, right? It doesn't make sense at all. Like, he had meningitis from some bacteria, probably chleb, since that's what was in his blood, but we didn't grow anything. And so, once again, the perfect example, that's why we treat white cell counts more often than we treat cultures here, because we just don't trust our cultures, okay? Make sense? All right. The infant at risk for sepsis, what do we do? So we have some protocols that I'm about to run through with you guys to kind of help you with that. Infants with concern for infection, so we classify based upon risk factors for maternal and that which is inherent to the baby. So maternal risk factors, so premature rupture of membranes, choreo, their risk of sepsis, prematurity. Infant factors are when you actually convert over to the rule out sepsis piece. So if they have fever, hypothermia, hypoglycemia, lethargy, respiratory distress, prematurity, prolonged resuscitation, those things are rule out sepsis, and those are baby factors. So once again, risk of sepsis, premature rupture of membranes, greater than 18 hours, infants doing well, maybe do a blood culture and admit the baby and monitor off antibiotics. And then if the blood culture is negative at 48, 72 hours, then you discharge, return precautions with mom, and go from there. Does that make sense? All right. Versus risk of sepsis with choreo, maternal fever, other signs, blood culture. With choreo, I would start antibiotics, okay, and then consider a CBC plus or minus a CRP at 6 to 12 hours of life. Once again, if you can push that 12 to 24-hour mark, then your CBC and your CRP is going to show you less about mom and more about baby. Does that make sense? Your blood culture can be drawn anytime. You don't have to wait for mom on that. Wait for 12 hours for that. And then once again, for choreo, if the baby's doing well, not having fevers, your culture is negative, then you can stop antibiotics, go home with good return precautions. Risk of sepsis, preterm infants. So preterm infant, premature rupture of membranes, any other risk factors, we usually start antibiotics, consider CBC, CRP, and admit the baby. Discharge when the baby is culture negative and the baby's not having any symptoms. And then there's other premature things that you've done away with, right? So 34-weeker, growing great, breastfeeding well, doing well, no fevers, was a little premature, maybe required a little bit of resuscitation at birth. Okay, we're going to probably do a blood culture. We're probably going to start antibiotics, but that's one. Maybe at 3 days, I would stop antibiotics and consider going home. Okay. Symptomatic infant, though, is always rule out sepsis. You always make sure you do your cultures and those kind of things and then start antibiotics. So rule out sepsis, absolute start antibiotics. Risk of sepsis, you may or may not start antibiotics. Does that make sense? Okay. Symptomatic infant, temperature instability, lethargy, anything else, evaluate, admit. If they are less than 24 hours of life, I would say blood culture, plus or minus urine, start antibiotics. Probably don't need to worry about CSF. If they're over 24 hours of life, you probably need to start thinking about everything, okay? All right. Symptomatic infant that responds quickly, turns around quickly, doesn't have ongoing fevers or symptoms. Septic workup virtually is negative, doing well, could stop antibiotics after your cultures are negative and go home. All right. Anything else we'll probably end up treating for a little bit longer. Late onset neonatal sepsis after 72 hours. So risk factors of late onset sepsis, prematurity, any type of central line, if they're on CPAP or nasal cannula or oxygen requirement, more than just TTN, okay, more than just transition, PPI use, GI tract pathology. So test is everything basically, right? Plus or minus chest x-ray if they have respiratory symptoms. Once again, get those things done before you start antibiotics if at all possible, okay? Antibiotics, so AMP and GENT are usually our first line. It provides good coverage against the most common organisms in synergy against Listeria. So AMP plus cefotaxime is the alternative. Your creatinine's over 1. You want to definitely not use aminoglycoside at that point, right? And then the other thing that we always think about is, I'll get that to the next slide. Cefotaxime is preferred over ceftriaxone because ceftriaxone is protein bound, may displace bilirubin and increase the risk of connectris. And so we don't really use ceftriaxone until they start getting around that 1 month mark or so, okay? Listeria. So Listeria is a hard one. It's one that always comes up. If you're going to see it on a test, it's going to be about neonates, okay? Listeria I've never seen in all my years of practice. Certainly here, because of the way plants maybe are fertilized, you may see it a little bit more. So feces has Listeria in it. So if you use any type of feces for fertilization, of crops and those kind of things, or workers that work with that, which can be every family, right? Then you can see a little bit more Listeria. But otherwise, Listeria is a hard bug to grow in lab. It's very hard to identify, and it's really not that common. So we always list it as one of the common organisms. It's really not that common. It's just it really affects neonates. That's why we always think about it. It's kind of like salmonella in sickle cell patients, right? It's not very common that we see salmonella sepsis in sickle cell patients, but it's a cohort of patients that really are affected by salmonella, and so we always think about it. Same thing's true here. With Listeria, we always think about it because they affect neonates, but it's not a super common thing that we see. Does that make sense to you guys? The other thing about Listeria is ceftriaxone, cefotaxime, those things don't treat Listeria. The ampicillin is added on for Listeria coverage primarily, okay? And so you always want to double cover with AMP and GENT or AMP and cefotax to help cover Listeria with your ampicillin. Does that make sense? All right. Okay. Gentamicin and cefotaxime increase resistance in nosocomial infections when cefotaxime is routinely used. Prolonged use of third-generation cephalosporins associated with candidiasis. Cefotaxime is favored in cases of acute kidney injury. So if you have true NICU doctors, neonatologists, they're always going to choose GENT over cefotax, okay? If you go to America, 100% of the time in NICUs, it's amp and gent, right? All right, unless there's acute kidney injury or some reason you shouldn't be using gent. We, as pediatricians that usually see parents go home and come back to the hospital, oftentimes we choose cefotaxime because we don't want to follow gent levels. We don't want to worry about the hearing loss. We don't want to worry about some of those other things. Then cost becomes an issue here too, right? So gentamicin is a lot cheaper than cefotaxime, so you would choose that. And so that's the difference between the two. The majority of the time, just kind of consider them equal. Gent and cefotaxime kind of work they don't work the same way, but they cover the same thing. Does that make sense? So your amps for something separate, gent or cefotax you're choosing to use based upon maybe AKI or something like that, okay? The other thing is, if we're going to treat for a prolonged period of time over 7 days, then we'll almost always do something with cefotax. So we'll use 7 days of gent for cost safety, but then we'll switch over to cefotax so we don't enter into the risk factors of you're having to follow creatinines or worried about sensorineural hearing loss or something of the sort. Does that make sense? Certainly, if you're treating 14 days of meningitis, you don't want to use an aminoglycoside that long if you don't have to, okay? So, but if we're just talking about 7 days sepsis treatment or something like that, then amp and gent's usually our choice, okay? AKI in that specific situation, we'll start with cefotax, and then when their creatinine falls to a normal range, we'll switch over to gent for cost purposes, okay? All right, almost over here, guys, okay? So, cases. Oh, it doesn't show you. That's good. So, case one, a 27-year-old prima gravida mother presents at 32 weeks gestation with complaints of leakage of amniotic fluid for the past 24 hours. The OB team starts her on antibiotics and on a course of steroids. 2 days later, a vigorous male infant weighing 1,450 grams is delivered. What are the risk factors for neonatal sepsis? Prematurity, low birth weight, prolonged rupture of membranes. First one maybe. Okay. What's your diagnosis? Risk of sepsis or rule out sepsis? Risk of sepsis. Okay. And what should you do? Blood culture and start antibiotics. Okay. See if you're right. What are the risk factors? What are the risk factors for neonatal sepsis? Prolonged rupture of membranes, prematurity, low birth weight, preterm labor. What's the diagnosis? Risk of sepsis. Y'all said that, right? Good. What should you do? You said antibiotics plus culture, right? Admit to nursery. Okay. Blood culture, insert IV, consider CBC, start antibiotics. Good job. All right. Monitor closely. Okay. Case 2. Term infant, prolonged rupture of membrane. 3.6 kilo female infant brought to the nursery due to concern of prolonged rupture of membrane. Infant is vigorous, well appearing, heart rate of 135, respiratory rate of 42, 93% on room air at 10 minutes of life. There is no low chest wall in drawing, no nasal flaring, RBS is 4.1. So what are the risk factors for sepsis? Prolonged rupture of membrane, which is how many hours? 18, right? Okay, good. 18. So, okay, what else? Is that all? Yeah, that's it, right? All right. What's the diagnosis? Rule out sepsis. Everybody agree? Okay. No. We have dissent. Okay, so we're half. So we got rule out sepsis and risk of sepsis. It looks like, and Victor doesn't know. What should you do? Huh? Blood culture. Everybody agrees with that. Admit to nursery, right? Admit to nursery. Blood culture. Consider CBC. Antibiotics or not? Okay, so even our risk of sepsis people here are saying start antibiotics, right? All right, let's see. What are the risk factors for sepsis, prolonged rupture? Oh, that's all we had. That's all we had? That's all we had, okay. What's the diagnosis? Risk. Okay, so y'all were wrong on that one. Y'all were right on that one. Okay. And admit to nursery, blood culture. Oh, all of you were wrong. No antibiotics. Monitor vitals, feeding. All right. Does that make sense to everyone? Do I need to go back to, y'all want me to go back to that one real quick? Let me go back to that one. That's one, right? Premature rupture of membranes, less than 18 hours, infants well. Y'all would agree with that? Admit, monitor off antibiotics, blood culture negative at 48 hours, discharge, danger sign. Make sense? Okay. Sorry to you guys watching on the video as I am speeding through this. Okay. All right. Case 3, lethargic baby. Newborn male, infant, weighing 2.3 kilos, brought to the nursery. Grade 2 meconium noted at delivery. Cried before suctioning was attempted. So obviously this is a little bit of an old slide. APGARs were 5 and 7. Poor tone, delayed cap refill, tachypnea, nasal flaring, lower chest wall and drawing. Oxygen sats at 78% on room air at 10 minutes of life. Further questioning learned that mother has been leaking fluid for over 30 hours. So risk factors for sepsis: prolonged rupture, preterm labor. Is there preterm labor? We don't know. Okay. Infant what? Melanoma? What do you say? What's he saying? I can't. Male. Well, yeah, there was a little bit risk of male, so he's not post-call. He's good. Still there. All right. All right. His weight's okay? His weight's okay, right? 2.3. It's a little bit small if he's term. We don't really know what he is, right? So it's a little bit small if he's term. Grade 2 meconium, is that a risk factor? Okay, cried immediately. APGARs, are those risk factors? Yeah, 5 and 7's lower, huh? Look at that. Poor tone, delayed cap refill, tachypnea, indrawing, 78%. All those things are not great, right? All right. And then obviously prolonged rupture of membrane, or, yeah. All right, meconium delivery, poor APGARs, symptomatic. Oh, wait, did we talk about what to do? Okay. What is your diagnosis, risk or rule out? Everybody agree? Rule out sepsis. What are you going to do? Admit to nursery. Blood culture. What antibiotics are you going to start? Okay, do you know your doses yet? AMP, how much? 50 per kilo, IVQ 12, right? IVQ 12, okay. And Gent 4, right? 4 per kilo per dose, which is Q term. OD, yeah. OD if they're term. If they're preterm, you may go to Q48 or 36 or something like that, right? Okay. So everybody agree with that? Anything else you want to do? Yeah, I think a chest X-ray would be a good idea here too, right? All right, meconium, risk factors for sepsis, meconium, poor APGARs, symptomatic, premature or prolonged rupture of membranes. What is the diagnosis? We said rule out, right? Risk and rule out. So we talked about that. We need to go back. Let's finish this and I'll go back to that slide, okay? What is the diagnosis? Rule out sepsis. What should you do? All right, admit to nursery, blood culture, IV, empiric amp and gent. Okay, I don't know about that one. Chest X-ray, right? Okay, chest X-ray. antibiotics until at least the cultures are negative at 48 hours, right? All right. Once again, pardon guys as I slide back through these to get the difference between risk of sepsis and rule out sepsis. Early and late. Wait, I went too far, didn't I? All right, where's that slide? So if you think of risk factors, maternal problems are risk of sepsis. Baby problems are rule out sepsis. Does that make sense? Okay. So choreo is theoretically a risk of sepsis. However, in choreo, you have active infection going on all around the baby. So we typically think about that as rule out sepsis, even though it's a maternal thing, okay? But anything else that you're thinking about as a maternal thing is typically risk of sepsis. Anything you usually think about a baby thing is usually rule out sepsis. So rupture of membrane, if the baby's doing completely fine, that's a maternal thing. We classify that as risk of sepsis, and we may or may not do antibiotics based upon how the baby looks, right? All right. Preterm labor, once again, is usually a maternal thing. If the baby's not super young, then we may just watch the baby, and it's more of risk of sepsis. So either risk or rule out, you're usually doing a blood culture, right? But rule out, you're usually doing a blood culture and starting antibiotics because the baby is involved and infected in some way. Does that make sense? I'll see if I come across that slide. It's usually more maternal because the baby usually isn't born premature because of a baby problem, most likely. It's usually born premature because of a mama problem, right? You agree? Okay. But I will say if the baby gets small enough, then it becomes a baby problem. If you got a 28-week, 700-grammer, we're probably going to do a culture and start antibiotics, okay? All right. Oh, here you go. Uh-huh. And it's what? Because so it not necessarily, meconium when it comes out may be sterile, but if meconium's been floating around in amniotic fluid for a week or two, then it's probably going to have some problems, right? Does that make sense? So you're increasing your risk of infection. And then obviously if they inhale it into their lungs, they're increasing their risk of a reaction to that, and they can develop pneumonia secondary to that. So it's a risk factor for infection that can become into a rule out factor. Does that make sense? No, not always. If they're doing fine. If they're not having respiratory symptoms, then we don't. No, not necessarily. If they're completely fine and doing well, and they're not having respiratory symptoms or other signs of sepsis, then we may not do anything. We may just watch. Yeah. So it's a risk, right? Not a rule out. So here we go. Maternal factors are typically risk of sepsis, including prematurity there. Infant factors are typically rule out sepsis. So fever, hypoglycemia, lethargy, distress. Prematurity is there too, and then prolonged resuscitation. Does that make sense? This is the slide I was trying to find. So, all right. And then, so risk of sepsis, premature rupture of membranes, choreo. We usually start antibiotics for choreo. Risk of sepsis for preterm. If they're late preterm or they're over, I would say probably 30 to 32 weeks, then we could just monitor them versus if they're earlier than that, we're probably going to start them on antibiotics. All right, let me jump back up to the case. Sorry, guys. Hide your eyes until I get there. All right, this is a baby that's coming back in now, okay? 7-day-old male infant weighing 3.9 kilos brought to outpatient clinic for newborn follow-up. Patient was born at term SVD without complications in pregnancy or delivery, no admission to nursery, discharge daylight 2, breastfeeding well, gaining weight. Triage nurses note that the patient is having blinking of the right eye, twitching of the right hand. Rectal temp is 36.1. Is that high or low? Huh? 36.1? Low, right? Slow. Heart rate 118. You would expect that of a 7-day-old? No, it's a little low, right? Respiratory rate 34, 98% on room air. Exam reveals the child with eye blinking, slight twitch to the right hand, even when held, not responding to your exam otherwise, crying intermittently. Upon asking mom, state started doing this on the way to the clinic visit, has not fed since morning. RBS check is 2.9. So risk factors for sepsis in this case. All right, let's go line by line. Looks like everything at delivery was well. Term delivery, no problems with pregnancy or delivery, went home. Breastfeeding well, has gained weight. And then you get to triage of the clinic. So what are the risk factors? Hypothermia, bradycardic, maybe from the hypothermia, maybe from something else. Twitching, what are y'all suspecting? Convulsion. Glucose is 2.9, low, high, normal. Little lowish, huh? All right, so risk factors. What's your diagnosis? Risk of sepsis, rule out sepsis. Yeah. So after you get past, that first few hours of life, you're no longer in the risk or rule out. You're automatically to rule out, okay? All right, and what should you do? Admit. Septic workup, which means blood culture, CSF, UA and culture, plus or minus CBC, plus or minus CRP. What else do you want to do to this baby? Yeah, so you probably want to, if you think it's a seizure, you probably want to address the seizure. You want to give some D10 too. Okay? Yeah. If you're in clinic with this baby, MCH or something like that, you want to get to casualty, right? Don't try to treat this baby right there. This is a baby you pick up and you go to casualty with, okay? And you start addressing the glucose and the seizure right away, and then get your septic workup done and your antibiotics done quickly, okay? All right, risk factors. So temperature instability, a hypothermia, decreased responsiveness, symptomatic for infection, probable convulsion, diagnosis, rule out sepsis, should you do, admit to nursery or HDU, CBC diff, blood culture, UA with micro, urine culture, lights, calcium. We didn't talk about that, right? So obviously could have that for seizures. IV access, empiric amp and gent, CSF, antibiotics at least until the cultures are negative at 48 hours, phenobarb. And I would say D10 too, okay? All right, questions? Any questions? All right, guys, sorry about going back and forth on the slides there, and thank you guys for watching.